Welcome to the Provider's Report, where we delve into the world of value-based healthcare. Our mission is to empower healthcare providers with the knowledge and tools they need to deliver exceptional patient care. Each episode, we explore best practices, innovative strategies, and real-world examples of how to achieve the highest standards in patient communication and outcomes. Join us as we transform the future of healthcare, one conversation at a time.
Hey guys, welcome to Better Doctor Project, where we interview healthcare providers to tap into their experiences so we can turn our challenges into our biggest strengths. We hope today's episode inspires you to take that next step to become who you want to be in practice. I'm Dr. Beck.
And I'm Dr. Mack.
Let's get started. We all know what to do when a patient comes in who truly needs to be our patient that day. But what about if they just don't? Do we know how to handle every scenario like that? Obviously, emergency medicine sure does. But what about everybody else? A couple years ago, I had a patient who had a pretty good size abdominal aortic dilation that I was able to diagnose upon imaging before treatment. If unstable, this could be a contraindication to treatment in my field. And even though the patient was in my clinic that day specifically for me to treat her back pain, I had to sit her down and tell her in that moment she needed to see somebody else first. Trust me, she was less than thrilled. When someone is having back pain to the point where they can barely move and that's all they can think about, and you have to tell them that you won't help them that day, it's not exactly a pretty situation. Nevertheless, I explained the issue, told her what to expect, both best and worst case scenarios, and then I told her how I'd follow up with her afterward. I referred her out immediately, and after a few weeks, she came back after advanced imaging and clearance. Then I was able to take care of her back pain, and she was extremely grateful. And more importantly, she was healthy and safe. Today's going to be part 3 with Dr. Shawn Neff as we dive into why we might need to say goodbye to a patient because they simply just need something or somebody else. Maybe the patient needs an immediate referral because something is going on that's life-threatening. Maybe you've attempted a couple treatment options, but the patient just isn't getting better. How can we successfully educate that patient about why the referral is necessary, and also how to make that referral process to another provider smooth? Some of us are in a hospital setting, which is great because sometimes this process is a little bit easier, but a lot of us aren't. How can we make the process just as smooth? Make sure you check out our show notes for some great tangibles to help you get started on this. And remember, parts 1 and 2 with Dr. Neff are available right now. So check out episodes 3 and 5 as soon as you can. Dr. Neff, welcome back. Great to have you on today.
Thanks.
Thank you so much for joining us for part 1 and part 2 of how to say goodbye to patients the right way.
Oh, it's my pleasure.
Thank you. Obviously, today we're going to talk about part 3, which is, I'll admit, the less fun reason to have to say goodbye to a patient, but it is incredibly important that healthcare providers know when to say goodbye because a patient truly needs someone other than us. Why do you think that this might be a hard concept for some healthcare providers? Why is it so hard to admit that maybe we're not the right fit at that current time?
Well, I think maybe ego is part of it. Certainly, I would hope that we all feel like we do a good job. Most of us have spent years and years and years and hundreds of thousands of dollars training to do the things that we do. So I think would certainly like to believe that we're good at it. Not being able to help some person isn't necessarily like the most feel good about yourself moment for sure. And then, there's also the unfortunate part that for better or for worse, healthcare is a business. We don't get paid for not seeing patients. That probably also impacts some people's feelings about it as well. So, it's something that makes you feel bad about yourself and costs you money. That obviously creates some disincentives for some people.
Sadly, yeah. Do you have any examples that you can think of right off the top of your head as a chiropractor where you've had to make that immediate referral? Maybe a new patient walked in and you could tell right away this was actually not a musculoskeletal concern at the given moment.
Well, the guy we spoke about last episode, with the inside the eyeball problem. Obviously, that's not a me problem. So that was an immediate referral.
And you had mentioned you had done an eye exam instead of a musculoskeletal exam, correct?
Correct. Yes, I had to do the musculoskeletal exam the next time I saw the patient when he was sent back to me.
Perfect.
So yeah, I previously had a patient. I know you're familiar with the story. It's actually been published as a case study. I had a patient who came in who presented as though he was having a verbal artery dissection. So he came in. There was a patient who was known to me. He'd been treated in the past for neck and back pain. He had presented again, but this time with complaints of blurred vision, double vision, difficulty speaking, difficulty swallowing. And this was also a patient who was in that 25 to 45-year-old window when vertebral basal artery dissections are more prevalent, although they're admittedly still an exceptionally rare thing. He also had some underlying vessel issues, having had a lot of vein varicosities, which can sometimes, especially in younger people, suggest that there's some vascular issues going on or connective tissue issues going on. So he came in presenting that way, at which point I did a very quick neuro exam, determined that he was having some neurologic issues, and I transported him via wheelchair to the emergency department for mostly because it was the end of the day, so getting him in for a CT angiogram would have been difficult. But coming through the emergency department, oftentimes they have the availability to call back in staff for doing those imaging studies that would normally only be done during business hours. So I took him to the emergency department, and I actually was on the phone with the emergency physician several times throughout the night as we waited on the different imaging studies. And it actually turned out to just be a very heavy neurological presentation for a migraine. It was just an abnormal presentation of a migraine. So he ended up coming back to me the next day, and we treated him with success. But in that moment, where we're dealing with potentially life-threatening condition, that I think that's the easiest call to make. The harder ones are the calls when there's not an obvious, clear-cut emergency. I think those ones are harder for people to just call, where maybe a patient's not getting as better as you'd want. Or they might just be better served by another provider with a different technique or in a different specialty. And I think those are the harder calls to make than the ones that are just blatantly, obviously an emergent condition.
Definitely. Let's use that eye patient a little bit further. How did you get down one-on-one and have that conversation with him without instilling fear when you had to tell him that he needed to be checked by the emergency department first? What kinds of phrases or terms, how did you lead that conversation?
I just explained to him that his eye condition was a problem with his eye, and that he needed to see an ophthalmologist, and that the fastest way to see the ophthalmologist was to go through the emergency department, that the emergency department also wouldn't be able to do anything about his eye. So I think that kind of let him know, like, look, you're going to have to go wait to see an emergency room doctor so that they can refer you to somewhere else. It's obviously not the best sell. Like, I need you to go wait for 4 hours to see someone to send you to the same place that I want to send you, but they can get you there quicker. It's not ideal. It's just the realities, I think, of practice in medicine in the United States.
Definitely. And so for people who are in private practice, let's say another type of life-threatening condition walks through their office. Let's say it's 4:00. It's about to be one of the busiest times of their day. They recognize they have to send someone literally immediately to the emergency department. It could be a AAA. It could be a heart attack, you name it. Let's say that patient has to go there. You're booked the rest of the afternoon as a healthcare provider, of course. What are some options for how you can ensure that that patient knows what to do, gets there efficiently? Who do you call? Do you contact their emergency contact? What are some things we can do to make sure we're not abandoning that patient in that moment?
you can send them via ambulance.
Exactly.
Then they're getting there.
Exactly. What if a patient refuses that?
If they refuse that, I would. If you believe that it's necessary for them to go in an ambulance and they're refusing, just for medical legal reasons, you should be having them sign an AMA letter stating, look, I gave you guidance. You're choosing to refuse to accept that and accept the responsibility for that choice. Because, this person could, like in the AAA example you gave, if that ruptures, while they're driving to the hospital, they could not only die, but they could kill other people. So obviously, trying to keep that from happening is the best thing you can do. But in the event that you can't keep them from doing something less smart, I guess covering yourself from liability for their bad choice would be the next best thing.
So let's say they do finally take your advice or at least get themselves to the hospital in some way, and they follow up on their care with another provider. At what point do you reach out to them to follow up with them to check in? Do you check in with those other providers? What are your sort of standards for reaching out and making sure, one, of course, that the patient knows you care, and two, to make sure you're aware of everything that's happened since the last time you saw that patient in that emergency situation?
Generally, if I have a patient who has something that I believe to be life-threatening, I'm following up just so I know what's going on with them, because I care, because I want to know that my patient's okay. Once they're stable, then I generally follow up with the patient just to let them know that I know what's going on. For non-life-threatening things, like if I have to send a patient, for a procedure or for some other treatment, where I know there's going to be some time before I can see them again, I normally just tell them to give me a call if they need anything, but just to call me when they've been released from post-surgical restrictions. For instance, I had a patient who had mid back pain that we were able to treat, but it just kept returning. She was exceptionally busty, so she had a lot of excess breast tissue. And so she opted to have a breast reduction. And so obviously following the breast reduction, there was a period of time where she obviously wasn't going to get treated by me. So I checked in with her and let her know, just, if you need anything, call me. But, once your surgeon releases you to be able to cough, sneeze, and lift things, when you're free with no restrictions, then call me and we'll go ahead and get you scheduled, for any other care that you need.
Well, and it sounds like your biggest strength with every story that you've mentioned in part 1, part 2, part 3 of this episode series that we're doing, you're clearly setting these expectations along the way, whether it's a great expectation or a not so great expectation. So patients know what they're going to get from you and they know what they're not going to get from you. And I think that's why you've had so much success with this.
Well, I think, people like to know what's going on. And I think that if you let them know honestly what's going on, that's usually the best way. If you try to make things sound too good and then they're not, people don't like that. That's an overpromise. People don't like an overpromise and an underdeliver. So, and healthcare can be scary because, patients don't necessarily understand everything. In much the same way, like I don't know that much about how my car works. Certainly not well enough to repair it. So if I feel like my mechanic has my best interests at heart, then I don't feel like I have to understand everything. They can just kind of let me know roughly what to expect, and I trust them. Whereas if I feel like they're not looking out for me, I feel like I need to know what's going on, and I'm probably not going to get to mechanic level expertise in a short amount of time. So I'm going to feel uncomfortable with that situation. And I think that's the same way our patients are. So as long as they feel like you know what's going on and you're advocating for them and you're giving them, information to let them know where they are and and how they'll know when they're at whatever point, I think they feel comfortable with that. But if they don't feel like you're looking out for them, they feel like they need to understand everything. And unfortunately, there's just no quick way to, 10 years of school.
That's another theme that's been coming through with part 1, part 2, and now part 3 of this too, is keeping the patient at the center of your focus, whether it's working with other providers, right? Or it's just how you're explaining it to them. They're going to feel that, and they're going to feel the fact that you care. And like you said, patients do want to know what's going on. And now, the more than ever, they have access to that, right? Dr. Google is a real thing. So
Yeah.
how has that changed your discussions with patients when they bring up, well, I found this knowledge here, or, some kind of treatment or concern that they have? Most of the time when we're talking about an unsuccessful treatment or bad news, right? Or what would appear as bad news, the next thing they do when they leave your office is they're going to Google it, unless you provide them with enough information where they feel satisfied. And they may even Google it anyway, or their friends or family. So how has that changed your conversation with them?
So I guess I have the benefit that I've never practiced in a time when patients didn't have Google. As old as I look, I've only been practicing since 2003. So the internet's been a thing all along. So patients have always been that way as long as I've practiced. And I think in general, if somebody gets a diagnosis, they're totally going to Google it. And so the next time they come in, especially if you're not the person who gave them that diagnosis, they've already read more about it than you probably have that day. So don't be afraid to tell a patient that you don't know the answer to something, but just make sure at that point you go find the answer. There's lots of times when patients come in with, like metabolic disorders have a tendency. There's a lot of rare metabolic disorders that exist. None of us know everything about all of those. So when they come in and say, hey, I have this polysaccharide thing, they don't expect you to know about it. But I do think they expect you to learn about it.
I love that differentiation too. And I found that even in school as a student, I always suddenly had the utmost respect for teachers if I or another student asked a question and they said, I don't know, but I'll find out for you. And if I can't, we'll look together. And I just think that is just such a genuine way to approach, I guess anything in life, but certainly students and patients, because we're all here to learn.
Well, and I think what you said before, just making sure that the patient knows that you care. I know when I was in school, I had a professor who told us, that a patient doesn't care how much you know until they know how much you care. And they still expect you to know stuff too. But, like I said, if they don't feel like you have their best interest at heart, it doesn't matter how much you know, because they're not going to feel comfortable with what's going on, because they can't know enough to feel comfortable with the process.
Absolutely.
Very good point. Now, to wrap up part 3, I really want to dive back. You kind of mentioned indirectly that, when a life-threatening condition walks into our office, those are sadly the easier ones to refer, because you automatically know, okay, heart attack, I need to send to this place. They're relatively easy to decipher what the solution is. You mentioned that it's not as easy to do it when it's not a life-threatening condition. So can you provide an example of that, and perhaps a patient experience you've gone through where it's been that way? And maybe by just switching their care from you to somebody else in a non-emergent area truly made all the difference in the world to that patient.
Yeah, absolutely. I think, everybody's had that patient that's, appears to be decidedly in your wheelhouse, but just doesn't get better for whatever reason. So, there are low back pain patients that I've seen who, by everything you see in the exam, you'd expect them to get better, and then they just don't. And I think if you enter in, knowing what success looks like and what failure looks like, you realize when you come to that point where this isn't working. And at that point, your duty is to either change what you're doing or send them to someone else who can help them. I think either of those things can be reasonable. So say, you see them, they're not getting better, you switch what you're doing, and then they're still not getting better. At that point, it's probably time to try and find something that's going to work for them better, whatever that is. And I think entering into it with the realization that, that might be a bit of trial and error moving forward as well, because you expected them to get better with what you were doing. Maybe it's time for more imaging. Maybe it's not. Maybe it's time for more diagnostic testing. Maybe it's not. But it's certainly probably time for a different approach.
When you've made that decision that you are going to try a different approach and you're going to refer that patient, is there anything in particular that you always include in your referrals to another provider? Or conversely, if another provider is reaching out to you and sending a patient as a referral to you, is there something that you really like to see in that referral? Any pertinent patient information you include? What really helps you in your administration of treatment for those individuals?
So actually, this past week, what I've been working on is we've been writing a new consultation template for our interdisciplinary pain team at the hospital. And so we've been having a lot of discussions about the information we'd like to have. Now, these patients are obviously, this is a tertiary referral clinic for patients with complex chronic pain. So these are patients with significant biopsychosocial overlay. These are patients who have, opiate use disorder. These are complex pain patients. And so we've been talking a lot amongst our interdisciplinary team about the information that we'd like to have. And really it comes down to the same things that I would like to have, in my chiropractic clinic is, obviously what the condition is, where is the pain, what's the quality of it, the location of it, is it dynamic or static, what things have been tried, what seems to help, what doesn't help, timing, all of those sort of things, just to give you the best picture of what's going on. And I certainly try to do that when I send someone out for anything. Here's what I think is going on. Here's what I've done. Here's what I've tried. Here's the diagnostic things that we have, just so that they can have the clearest picture. Now, obviously, for the chronic pain team consult, we also have, is this patient, receiving mental health care? If this patient's on antidepressants or antipsychotic medications, are they up to date? Those sort of questions also become a part of it. Has this patient had, a screening for the different medications that they're on? Have they had a urinalysis? So, depending on what condition you believe it to be, I think then you start to, to decide what information would need to be in that. If a patient's having chest pain and I'm sending that to cardiology, what are they going to want to know about the chest pain? Well, when are they having it? How severe is it? What are they on medications? Especially cardiology related medications. Have they had any studies done? When's their last EKG? Have they had any cardiac imaging? I think the more information you can give the consulting provider, the better outcome the patient's going to have, and the more appreciative the provider will be. I think we all get enough of the kind of, blank referral where they're like, hey, take a look, and they don't really tell you anything. And that, doesn't allow you to prepare as much beforehand, or you have to spend a lot of time, as my colleague who's a physiatrist says, being a detective. You have to be a detective and find out what's been done before I can figure out what I'm going to do. And that takes a lot of time away from treating the patient. So, yeah, I think the more information we can give, the better. But without just dumping a bunch of useless stuff in. A concise presenting of important information, not necessarily just giving them all of the information about everything that's not useful to where you can't find the things that are important.
We've talked a lot about in this episode and especially in others about functional goals and the things that really matter to the patient. And that's something obviously that's really important when you're creating a treatment plan. Is that something that you ever include in your referrals alongside your pain and examination findings?
sometimes, depending on what the referral's for. So when I'm referring to the chronic pain team, I generally include, what my goals are for the patient or what the patient's goals are for themselves. If I'm referring to physical therapy, yes. If I'm referring to cardiology, less so. To be honest, they're a little less patient goal driven in cardiology. Just, differences in the types of conditions that we treat. No, with pulmonology, that's one where it could go either way. Obviously you're sending them there because you want the patient to be able to, breathe better or have better lung function, but sometimes that also translates into the things that they're able to do as well. The patients have goals about that. Maybe they want to be able to hike or go for a walk. And that's important, I think, for the doctor to know when they're getting that referral. But yeah, I think, like I said, a concise telling of the important information as close as you can get is the best way to move forward with that.
Well, and it can go both ways too. I know for me personally, when I write my letter, I'm instantly thinking of myself in that provider's shoes. For example, if I'm being sent information about a cardiac patient or an EKG, I only want the basics because I don't spend my entire day reading EKG results, right? So if a cardiologist sent me a full 1-page report explaining in every single little detail what that EKG says, it might be a waste of that provider's time, right?
Yeah,
I need to know
absolutely.
the pertinent information. Can I continue to treat and co-manage this patient? So I really encourage people when they are writing a letter, when they are doing this type of referral of any kind, to kind of put yourself in that provider's shoes. Exactly like you said, keep it concise, keep it to the information that they're actually going to care about, and the information that's actually important too.
Yeah. And I think another thing to think about when we're referring to other providers is essentially knowing what the patient's going to be going through so we can pre-orient the patient for what's going to happen. Because those referrals, they're going to a provider that they haven't seen before, maybe in a facility they haven't been to before. And that can sometimes be scary, especially when you're talking about things like injections or surgery. People usually have, some anxiety build up around needles and knives. So I try to do a good job of orienting the patient, like, look, this is what's going to happen. This is what they're going to do. When I'm sending a patient to go have a surgical consult where surgery is maybe not a clear cut, this is definitely going to happen. I always tell the patient, look, getting more information is always a good idea. When you walk through the door, they're not going to throw you on the table and surgery you. They're going to talk to you. They're going to do an exam, and then you're going to come up with a plan. They're not going to catch you in the waiting room, chloroform you, and do surgery on you when you're not paying attention. That's just not the way it works. And I think, sometimes, having that humor to it also helps. But I know our interventional anesthesiologist will, sometimes come back and say, hey, I saw so-and-so for a sacroiliac injection, and I really appreciate that you kind of explained to him how it's going to work, how long it's going to last. He said, I went to go give him the whole spiel. And he said, no, Dr. Neff already told me, I should notice that it's better by this point in time, as long as it lasts so long, then it was successful. And so I think sometimes hearing it more than one time is good for patients so that it helps make sure that they know what's going on. And it helps, I think, create some pre-trust with the next provider. And if the other provider is a person that you know and trust, tell the patient that, because it always helps, to know that, hey, this is somebody that I know and trust. I'm not sending you to somebody that I don't know.
And that's a great way to make possibly a not so fun dismissal of care / referral appear lighter, appear more positive. If you can say, hey, I'm referring you, for a surgical consult, you might need a laminectomy. If you can sit down and explain to them, even in just the most basic format, what a laminectomy is like, if they need it, they're instantly going to have pre-exposure to it. So when they go there, they're obviously going to be, having less fear. They're going to possibly trust that provider a little bit more, just like you mentioned. And you're starting that process, making that a more positive thing instead of a negative. Yes, is it unfortunate that they didn't happen to respond to your care? Of course. I wish everybody could respond to one treatment for everything. The world would be a totally different place, but it's just not the reality. So when we have to have these conversations, we can make them positive, and you just explained that to a T. So thank you.
And I think, giving the patient that information in the front end maybe helps inoculate them from the uncertainty that causes them to seek out Dr. Google or Dr. YouTube. And I think generally YouTube, although there's some great sources for some health information on YouTube, I don't want to make it sound like there's nothing of value on YouTube, but generally YouTube requires some expertise to curate what's good and what's bad. I certainly wouldn't necessarily be ideal for me if every patient who came to see me, their first exposure was just YouTubing chiropractic, because you see a lot of crazy things on there that I personally find horrifying. And I certainly wouldn't want people heading in with that expectation.
Absolutely.
And I would guess that it's the same for any provider. But by orienting them before, maybe it saves them from doing that before they get there, and they don't see the nightmares that the internet has, lurking around.
Well, I think everything you just explained, I think the people listening to this right now are going to be able to take this, again, make this negative situation more positive, and immediately start to have better referral processes. So I thank you so much for joining us, Dr. Neff. It's been an absolute pleasure.
All right. Thank you so much, guys. Take care.
I'm so glad you joined us for this final piece of our 3-part series on how to say goodbye to patients in various care scenarios. I hope this episode got you thinking about how you're going to work on improving your referrals with just the right amount of pertinent information, keeping them clear and concise. And I hope that this got you ready to help guide your patients through their sometimes scary next steps. Keep your eye out for tangible items coming really soon to further outline these for you, to help you make these transitions smooth in practice. In the meantime, make sure to invite your healthcare colleagues to join us on Instagram at Better Doctor Project. See you there. We loved connecting with you today on this episode of the Better Doctor Project. We can't wait to share our next podcast with you in just 2 weeks. Same time, same place. Until then, pop over to Instagram to follow us at Better Doctor Project, or keep up with us at betterdoctorproject.com.
Thank you for tuning in to the Provider's Report. We hope you found today's episode valuable and inspiring. To stay updated with our latest episodes, subscribe to our podcast wherever you like to listen. For more resources and continuing education opportunities, visit our website. Together, we can make a difference in the lives of our patients and truly set a standard for value-based healthcare.